as you've seen through the range of talks we had, there were a lot of talks around probabilistic ML, causal ML, different types of theoretical frameworks around ML, multimodal ML, and so on. And through the next talk, we want to kind of touch on some of those, but at the same time, emphasize the importance of taking those MLs to clinic, to the real world, to the applied world. And I don't think there's anyone better than Professor Kazem Rahimi to have that lecture at the school. So Kazem is a colleague. We are together part of the Deep Medicine program. He leads the Deep Medicine program at the University of Oxford. He's a professor of cardiovascular medicine and population health at the University of Oxford and a consultant cardiologist within Oxford University Hospital NHS Trust. His research interests includes hypertension, heart failure, multimorbidity, and cardiovascular risk management using a variety of methodologies, including, but not limited to, machine learning. He also leads the Deep Medicine program, University of Oxford, and projects such as BPL-2CC, which is one of the biggest consortiums of clinical trials on blood pressure reduction. And also within the Deep Medicine program, his research focus is around the use of machine learning approaches to multimodal medical data, such as electronic health records. So with that, please join me in welcoming Kazem Rahimi to the stage.
Thank you. I hope that you have been enjoying Oxford, and I'm sure you've been learning a lot looking at the program. So this talk is going to be relatively light. So as Reza introduced me, I'm not a data scientist. I'm a clinician by training, as well as epidemiologist and clinical trialist. But over the past few years, leading the Deep Medicine lab, we have tried to essentially converge the two worlds. So I don't know how many in the audience have got background in the traditional epidemiology statistics. Perhaps you can raise your hand. Good. So a few. So for those of you who've got that background, it might be a bit slow or boring, but I try to just essentially go through the slides, cover those areas gradually. But before going into that, as a clinician, it is worth looking at which areas in medical practice lend themselves to disruption with machine learning and AI. And the way to look at it, and this is how I conceptualize it, let's have a look at what a doctor does, or a healthcare professional generally. If you break down the type of activities that a healthcare professional does, you could roughly group them into these three types of activities. One is making diagnosis. That is someone coming to a hospital or to a doctor and presenting with some problems. And the question to the doctor is, what is going on here? To make a diagnosis. This is essentially based on the information that has been available to just say what is going on now. So you can think of it as a prediction of a problem, as a pattern recognition. The second type of activity the doctor does is prognosis, telling the individual what is the trajectory of the disease in the future. So this is a type of a prediction looking into the future, forecasting. And the third category of decision that doctors make is about intervention. What should I do? Should I give drug A, drug B, nothing? And what are the consequences of those decisions for an individual's health? And this one is, of course, a type of a causal prediction that goes into that. And over the past few years, we have seen a lot of development. I was just talking to Reza before my talk earlier. When we had the OXML last year, compared to this year, there has been a transformation in terms of the technologies actually entering medical space. And as one of my other roles, I'm a member of the National Institute for Clinical Excellence in the UK. And we see a lot of companies bring their products to the UK and wanting to just get approval from the regulators, and then later on from the payers to enter them. And there was virtually nothing a couple of years ago, and we see an exponential growth of those technologies. And most of them fall into the category number one in terms of making a diagnosis. Some of them fall into the category of helping with the back office activities of helping with administration. We haven't seen many on the intervention side, the causal inference, But if you look at these lists, what is common to them is, of course, prediction comes across all of those activities. And given that machine learning is all about prediction, you won't be surprised that pretty much all activities in healthcare are subject to disruption. But I'm going to mainly focus today on a few examples of the work that we have been doing on intervention, starting from the end of how we have been doing it traditionally and where we think that ML could help. So there are different ways of trying to define what causation is. In a simplified way, this is how an epidemiologist would look at it. So you've got a relationship between A and B. In terms of causation, what you want to see is that changing A would change B. It doesn't work the other way around. Changing B would not change A. So this is what we mean as causation. Changing A leads to B. And A, we call them in the conventional epidemiological world as exposure, and that could be something, your blood pressure. Changing blood pressure will change the risk of someone suffering a heart attack or a stroke, or giving someone a drug would avert that happening. And the outcome would be cardiovascular disease. So I'm going to remain, given my clinical expertise in cardiovascular area, I'll stick to the example of a blood pressure and some of those drugs throughout the talk. So that is fairly straightforward, looking at A relationship with B, and that association is not causation. You want to make sure that it doesn't go the other way around. But the key factor in that relationship is C, something that we call confounder. So you want to make sure that the relationship that you observe is not due to factor C. As a confounder, you can see it also as a common cause. There might be a factor that affects both A and B, and what you observe between A and B is just a reflection of C affecting both of them. And remaining in the same example, you can think, for instance, at body weight. If you become more obese, if you gain weight, your blood pressure goes up, and your risk of cardiovascular disease also increases. And this is the context when you need to disentangle to what extent does blood pressure on its own affect the risk of cardiovascular disease. So traditionally, of course, there are good statistical methods where we essentially adjust for those known and measured confounders and look at the relationship. To remain with the same example, the way we have been doing it traditionally is to come up with prospective studies, cohort studies. You start with a group of individuals. All of them are relatively similar and healthy, ideally. You measure their blood pressure today, or any other risk factor that you might be interested, and then you follow them up for several years, and then observe what would happen. If you have managed to control for that C, you would get a sort of an unconfounded relationship where you can assume that this is causal. And this was done here in the case of a cohort study already a couple of decades ago, where people's blood pressure was measured here on the x-axis. People were grouped into different blood pressure categories and then followed up for several years, about a decade. And then on the y-axis, you look at the relative risk of those individuals suffering a stroke compared to the others. And what this shows is that the lower an individual's blood pressure, the lower the risk of them suffering a stroke. And that has been extended. If you manage to get, it's not a sort of an old science that have changed because, the world is becoming more complex. The relationship is still valid. In fact, if you manage to identify healthier individuals whose blood pressure goes further down, you see that continuous log linear relationship goes all the way down to a systolic blood pressure of 90, which is very low. So this is the pattern that we see, and we are relatively confident that this relationship is likely to be causal. The issue that we always have, however, that applies to those studies that have shown as well, how do we know that we have taken account of all those confounders? In a study, of course, you can only take account of the confounders in a conventional way if you have known which of those are going to be an issue and you have measured them. So it's always the question of, is there any residual confounding that you have not taken into account? And in the sort of a conventional paradigm of medical science, The best way of addressing that is through randomized controlled trials. That is why they're still considered to be the gold standard. How does it work? You start again with the same population, you select a population, and the beauty is here that you could select any population that you're interested. You don't need to worry really about any of the confounders, and you don't need to have any knowledge of the confounders. Because what you will do, you will then essentially toss a coin. You will randomize those individuals into typically 2 groups, but could be multiple groups. And that randomness essentially balances the prevalence of those confounders into 2 groups automatically. You can assume if the population is large enough that by chance, as many people, let's say, would be overweight in your group A as in your group B. So they're automatically balanced, right? And that applies to any other confounders that you might not have thought of. And that simplifies really the statistics. So you can now give sort of one group a blood pressure lowering drug, the other one give them no drug, and then you just simply follow them for a few years. And then you look at how many people at the end up having, let's say, a stroke. Likely to be in one group lower than the other one, and you just calculate the ratio and you know what is the relative effect. Very simple statistics too. In fact, if someone has worked as a statistician, working on clinical trials is just really such a dead boring job, because you don't have to think about anything. It's about project management. You get the data collected and you just need to calculate a ratio fundamentally, more or less. And that job is done. And fortunately for blood pressure, we've got that evidence. There have been hundreds of thousands of people who have been included in such trials. And if you do that, you get a graphs like this. On the x-axis is time since randomization. On the y-axis is that essentially calculation that I just mentioned, group A divided by group B. And what you can see, the red line is people who have been given a drug. Blue line is people who have not been given a drug, and you can see clearly that the risk is lower if you have been given a drug. And you can be certain that confounding does not play a role. You can be certain that the average treatment group here is causal, because by definition, as I've just said, the confounders must have been balanced between the 2 groups. The problem that we have is, that could, of course, end the debate about, more complex modeling. The problem that we have is that clinical trials are just so complicated and expensive, and sometimes they're unethical to be done, and it's very hard to just get certain populations volunteering to participate into clinical trials. But the main reason is really the cost. Including one person into a new drug trial at the moment cost about $40,000. That is the cost of one individual included in the study, followed up for several years. It involves the cost of course, drug packaging, distribution, paying doctors to just recruit people, administration, regulatory, and so on, right? And that is probably an underestimate of the cost. The costs are increasing by the day as we speak. Typically for a new drug, you have seen it in vaccine trials, how many patients need to go into these studies. For many of those drugs, given the modest relative effect, you would need to have, let's say, 10,000 people in the clinical trial. So you get to the budget of $40–50 million for a single study. And you have to essentially wait for 6–7 years to get to that point if it is a long-term intervention. With COVID, of course, we just looked at the short term. But the costs were really similar. This is the cost that you have to look at. And that is just not scalable. Still we will have to do it in some areas. It's still the gold standard, but it's not scalable. We can't do it. We can't do it in every single patient group. So, of course, the one question that arises here, can we use electronic health records to just help? Before going into electronic health records, it is perhaps interesting as a sort of a historical example to just show that the type of administrative data have already been used. This is nothing new for learning about relationships of some certain risk factors and disease. And in fact, blood pressure is one of the good examples for that. where the first description of the relationship between elevated blood pressure and death did not come from some cardiologist or clever epidemiologist or scientist. This came from an insurance company. So American insurance company in 1910, they looked at the life tables. You know, they have measured, of course, certain things about the patients. They're about the clients. They're not patients. And then someone, you know, looked at the tables at some point and found that it is odd. You know, people who have got a higher blood pressure tend to die earlier, right? And that was the conclusion that they made at that time. Mortality increases rapidly with the increase in blood pressure over the average. So if you have above the average, you know, you're more likely to just die. If your blood pressure is higher, your risk of death is just higher. So this started there, right? It just shows the power of some of those administrative data. But it works in certain settings, right? You know, the signals need to be really strong, and you know, in that observation that they've made could well have been all due to confounding. You know, they didn't know probably what confounding is at that time. It happened that it just came out later to be causal, but it could have been just a spurious relationship. But it works in certain circumstances. But it also fails in most circumstances that we are interested in today. So this is just looking at this the same example of blood pressure and risk of stroke. So a lot of the time, I mean, we know now a lot that, you know, the lower the blood pressure, the lower the risk of cardiovascular disease in most patient groups, right? But clinicians and a lot of the time the patients themselves are interested, does it apply to me as well? I mean, I've got an underlying health condition. I don't know, I've got a chronic lung disease, I've got diabetes, I've suffered a stroke previously and I've survived it. Does it apply to me as well? I mean, my blood pressure is messed up since I had that condition, or I take, you know, 20 different drugs already for my depression and for my Parkinson's and everything else, right? Does it apply to me? So this is the best attempt from the conventional statistics to trying to answer that question, because we don't have randomized clinical trials in every subgroup that we are interested, that I described as few examples of it. So what would conventional statistics do? The same thing. You look at a cohort of people, let's say, you know, they have diabetes, and you just look at the same relationship, trying to just adjust for the known confounders that you happen to have measured in your database. And a lot of the time you get, you know, these kind of relationships that we call a J-shaped relationship, which has essentially an optimum somewhere in the middle. As the blood pressure goes up, your risk goes up. As the blood pressure goes down, the risk goes up too. So this gives us essentially a very different message for decision making. It suggests, well, probably in that group you should be careful. You know, it might be that generally the lower the better, but in that group you should be cautious and you should not be doing anything. But of course, one of the issues is you don't know whether this relationship is causal because of the complexity as many of these patients groups have. And again, for some of them, we are fortunate to have some randomized evidence, and when we test them, it turns out that yes, they are likely to be spurious. You know, here, for instance, and the way we do it conventionally in epidemiology and statistics, just saying we start again with the same randomized population and just saying, okay, so let's see how many of them had diabetes by chance, let's say, how many of them didn't have diabetes, and you look at the interaction between the two groups, and that is shown in this sort of a top section of this slide. As you can see, the relative risk reduction between the two groups is exactly the same. So you can conclude, well, there is no difference. And you can, if you're fortunate, and for blood pressure, we are fortunate, we've got a lot of previous trials, you can split them further, as shown in the bottom section, by different blood pressure categories. Again, you do a sort of a conventional test for interaction. You don't see anything, and you're sort of relaxed that, you know, what people have reported in the previous study. And as you've probably noticed in the footnote, this is not just all of it landing in some sort of esoteric journal. So this one was published in the Lancet. So this is, you can assume that they have applied the best methods available and have been scrutinized by some of the top statisticians that the journal still has made it into that. And this is what a lot of people still believe. So as I said, if you're fortunate and you've got some other data sets, you can do the stratification, so splitting it and then comparing it, and that suggests that, you know, many of those cohort studies with the conventional statistics probably were just wrong. Now let's get to the electronic health records. And the question is whether, we can use ML, where we haven't got that fortunate situation of having RCTs, to get better answers than those sort of J-shaped curves that some of those studies have shown. And what are electronic health records? I mean, that is essentially a summary of everything about our health interactions in an ideal scenario with the health services. When we see the doctors, information is captured. You might have vaccination, you might have some measurements, you might have admitted to hospital, you might have been given drugs, and so on. So this is essentially a trajectory of individuals, and that, as you can imagine, there is, unlike a cohort study where you would have regular visits where certain things are collected in a standardized way, there is no standardization in routine care at all. So they happen to get collected at one level of individual, very different from another. And you could essentially cut the data at some point, just saying, this is where I want to start my observation. I consider everything that has happened before that as a past, and I'm interested to see what happens in the future. So when we run those analyses with the conventional methods, as I mentioned earlier, the issue that we are facing is that we are not certain whether we have adjusted for all important confounders. So the term that is a lot of time used is residual or uncontrolled confounding. So in other words, we are not sure whether those individuals, let's say at the bottom tail of the blood pressure, are similar in every respect to those at the higher end of the blood pressure, in every respect other than the blood pressure. Are we comparing like with like? And almost certainly in those studies we are not. So that is really the challenge. So what is, in this case, before we show some empirical examples, what is the theoretical advantage of deep learning in this scenario? So if you look at the same relationship, when we use all data in electronic health records, we can leverage one fact, that we don't need to specify all confounders. But in conventional statistical sense, an expert has to sit down saying, I think, I don't know, body weight is important to adjust for. That thing needs to be adjusted for. Here, you don't need to worry about it, because in most deep learning models, you feed almost the entire information that you have into the model, and you can assume if there was an important confounder that has been measured, it would have been included in the model, right? The second advantage is that even if your confounder has not been measured, you can leverage the relationship of that confounder with some other markers that have been recorded in the electronic records that I call a proxy measure for a confounder. And that is, of course, you know it from the transformer models and the deep learning models, that is essentially that contextual information that a lot of the time tells you a lot about an individual without having explicit information about certain features, right? So to give an example, one patient could have been admitted to hospital several times. So, sort of electronic health records is full of visits, or could have had, multiple tests for a certain condition. That signals something about that individual that might not be directly captured. Let's call it chronically sick, right? Or, having, multiple conditions, right? So that captures sort of indirectly through that without us having any coding for that directly in the database. And that gives you essentially the theoretical advantage that you can essentially capture those unobserved, unmeasured, or unknown confounders indirectly through those proxy factors. And the other advantage, I won't go into details of that, is that we don't need to worry so much about missingness of individual covariates, partly related to that proxy measurement, and that goes into the model. But let me just give you now some examples of whether it works and what are our experience in this area, and what the limitations are. Feel free to ask any questions if something is not clear so far, or doesn't make sense. We good? Yeah. So we started a few years ago with BERT, a transformer for electronic health records, and that was a, you can read, the papers are all available, open access, you can read about them, and most of the codes are also accessible through GitHub that people can access and experiment with. To just do exactly that, feed in the entire medical history of an individual and then look at what happens in the future for prediction task, and it looks good. It looks much better than any conventional risk prediction model. Without specifically tuning the model for a specific condition, it still can predict what is the next event in the future. That works. Moving from there, as I said, a lot of the interest in medicine is about causation, and Shishi Rao led that work here in this targeted BERT, where we try to just leverage the same architecture of the BERT by adding a few features to that, learning essentially from statistics and epidemiology in the mask model to predict the outcome in a causal sense. Just go to the sort of the results of a couple of studies that we have done to just illustrate how it worked. So this is coming back to the same example. Hopefully that makes it easier for you to just follow the red line in the talk. People with diabetes, as I've said before, some studies have shown, well, that relationship, the lower the better, does not apply to people with diabetes. And you can see it in the bottom sections of this slide where conventional statistical modeling is applied. And here you see essentially an implied J-curve in both of them. Interestingly, when you adjust them, the J becomes more predominant than a raw model that is not adjusted at all. But in both of them, this is the best that the statistical model can give. And this is really throwing in all the confounders that we know about today. But when we just do the T-BERT model, that becomes a sort of a linear continuous relationship with individuals who've got a lower blood pressure, have got the lower risk of cardiovascular disease happening in the future. So with diabetes, of course, that was just an exercise. Yes?
I just have a question about what I guess is largest standard deviation for the T-BERT model.
Yeah, it's just the way they're calculated. I mean, calculating the confidence interval in the sense of deep learning model is not the same as calculating confidence interval in the regression model. I'm not able to just exactly tell you why that is the case. I mean, you can read the paper just, but it's a good observation that you've made. So this is, hasn't got anything to do with the patient population, because a lot of time is the sample size that determines the confidence interval. This is not about that. This is purely because of the modeling. It has a sort of a larger uncertainty around it. So, for diabetes, of course, we know that, as I've shown you already the slides, that, we know from randomized clinical trials that because we have included so many diabetic patients in those clinical drug trials, we know that the observation should be continuous and linear. So this just confirms what we already know in a different format. So it just doesn't bring us much forward. But it offers us to just go to populations where we don't have any clinical trials. People with COPD or chronic lung disease, they are a high-risk patient group, and it's unlikely that we will ever have clinical trials of blood pressure-lowering drugs in these patient populations. So I think these sort of examples where experimentation with new methods are particularly useful. So you see the pattern, it just looks almost the same as I've shown before. You've got essentially J-curve for conventional statistical models, whether this is crude or whether this is adjusted, but it becomes pretty much continuous when the T-BERT model is applied. So far, what I've shown was about the risk factor relationship, blood pressure, cardiovascular disease, and, explain the confounding and the challenge of residual confounding to control in a conventional setting. But one of the most interesting areas in medicine where we want to have causal inference is about drug effects, right? You want to know if I would give that drug to an individual, does it perform better than another drug or not giving it at all? Does giving drug A cause, a lot of side effects and it should be avoided or not? So this is an area where, is also the most challenging area of conducting causal inference. Why? Because if you look at routine data where some people have been given a drug, some people have not been given a drug, it is almost certain that someone have been given a drug is different than from someone who has not been given a drug. In other words, there's a good reason why someone has chosen to give a drug to that one or not give that one. So it's very hard to just find matching of an individual who might be different in any other sense other than the drug given. So it's essentially that selection bias is what makes things very hard. So this is an example where we use the T-BERT for drug effects. And the motivation for us was this study. This is not what we have done. This is a conventional statistical model. To tell you what the story here is, this study was published in the European Heart Journal, which is one of the top-ranking cardiovascular journals, in fact, the top-ranking cardiovascular journal, and suggested that people who take sodium-containing paracetamol, so paracetamol is the #1 painkiller worldwide, is also called acetaminophen in some parts of the world, in North America. So it was suggesting people who take the sodium-containing type of that, they're more likely to die and suffer from cardiovascular disease than those who take the standard formulation of it. And these are sort of the summary results of that. They show that, and they split it because probably someone asked them to just do it. They split it in people who had hypertension or no hypertension, but you can ignore it for now. But they look at two outcomes, cardiovascular disease and all-cause death, cardiovascular disease and all-cause death. And people taking sodium containing acetaminophen are blue. The red is who take the conventional setting. And as you can just see, the red line is always lower than the blue line, suggesting that the risk in people taking the standard formulation is lower. And how much is it lower? And you can see sort of the hazard ratio, which is a notion of relative risk. It is, the risk is 60% roughly higher for cardiovascular disease if you take the sodium-containing formulation, and your risk of death is nearly double as high. And this is just in a relatively short observation period of a few months. So the risk is just start to converge, and you see the same in the other population. And what is the logic behind this? What is the justification for it? I mean, the justification is, to get those soluble formulations, you need to add sodium to the tablets. And we know sodium, salt essentially, but this is not exactly salt, is not sodium chloride, but sodium is a sort of a source of elevating blood pressure. So the logic is it raises the blood pressure, and blood pressure raises the risk of stroke, and therefore is a bad thing to be taken, right? And that has led to some regulators issuing warning. You can imagine this is a big thing, right? And it was in the news. You probably have not seen it. People just saying, oh, we should be careful. We should not be prescribing that drug, and so on. Or if you take the drug, you should be aware of the increased risk associated with it of you dying, in a sense, right? What made us curious is, if this is true, if the causal pathway is sodium increases the blood pressure increases the risk of cardiovascular disease, right? There are two things that are odd in the observation that has been made in this study. One is that the relationship is way too strong. The order of magnitude that you see here compared to what we know from drug effect is just too strong. And usually, is a good advice. If things look too good, probably they're wrong, right? It just should you make sort of suspicious about something that is not right here. The other thing is that it seems that it makes you more likely to die of non-cardiovascular disease than cardiovascular disease, which does not fit with that biological line of causation that I explained, right? Why should be more susceptible of dying of cancer if you take sodium, right? Doesn't make sense, because if that would not be the case, you would expect the hazard ratio or the association with all-cause mortality to be lower than cardiovascular mortality. But there's a stronger signal for all-cause mortality, which means the excess risk to other causes is even stronger than for cardiovascular disease, which is a bit odd. That shouldn't be the case. So that really smells of uncontrolled confounding and bias, and which, of course, again, top journal has gone through that. Despite all the tricks that we have today in epidemiology, have not been able to just get to the bottom of it. So let's do the T-BIRT. So if we do the T-BIRT, and we are fortunate that the journal has just accepted the paper to be published in the same journal. So, that, because usually they don't do that. They don't like the things that they've published before to be disputed. But, I think we are fortunate on this front. So when we look at it, the first thing is just saying we don't see any effect on blood pressure at all. So if there would in order to just look at the biological pathway, you need to show that actually the blood pressure changes. Actually, the blood pressure doesn't change. And it doesn't matter whether you split it in people with disease or without disease. And when we look at cardiovascular disease, again, you see it's flat. We don't see any clear effect. But when we look at all-cause death, we still see an effect. It's not as strong as what the other paper had reported. I mean, just for a reference, the other paper had reported a doubling in risk. We show it's increased by about 50%. So we have managed to do the deconfounding for the main biological pathway, but there's still something going on which shows probably either our model or the design of the study is still not perfect, or the database or some other issues. So that is where, essentially the interdisciplinary team comes into play to just trying to just disentangle the things that might be going on and do the detective work. And one thing that we identified is this is the typical design of the studies that we conduct, right? I mentioned it, you've got the electronic health records, use all the information before the drug is given for the first time as your learning window. This is where your model, if it's clever, will do all the deconfounding to select like with like. And then you look at what happens in the future in your prediction window. What if some of those confounders are not recorded in time before the baseline? They're delayed. They come later. There's no way that your model can learn that, right? Because you intentionally blank out everything that happens in the future, right? So you just look backwards only. And are there any scenarios where that could be the case? Yes. It's very common in medicine, right? Particularly for conditions that are incipient, right? I mean, for some acute conditions, I don't know if you've got a stroke, you get to hospital immediately. There is no delay in capturing the information. For some of them, you might have some issues and you feel unwell, and it takes months for you to see the doctor, and it takes a few months to just get the diagnosis. Or someone might be a delay of putting into electronic health records. It's very common to happen. So those models just don't take that into account. When we looked at it, we found that actually there are a number of conditions that have been recorded late. And one of the big ones is, conditions that are essentially the reason why you would be giving soluble paracetamol in the first place. So dysphagia is a condition where you've got swallowing difficulties. You can imagine if someone cannot swallow, they're more likely to be given something that they can drink, right? And sometimes that dysphagia was essentially recorded late. And that condition was not taken into account in that previous paper of expert modeling at all, by the way, including some other conditions that also have a high correlation with swallowing difficulties and dysphagia, like dementia. So a lot of people that take those drugs are at ill health, have got dementia. They cannot essentially take food in a normal way as we do. So that is why the diet is all in a fluid basis. So, and of course, they're more likely to die than others. So if you don't adjust for that because you didn't think about it, you didn't have it, your model is going to be confounded. So this is what we saw here, that essentially that taking those into account would diminish the relationship, would not entirely get rid of it. So there's still something going on that we can't do. But I think this gives us sort of confidence that certainly that relationship, sodium and cardiovascular disease, was not causal, and hopefully that should give a de-warning to practitioners about prescribing those essential drugs for people who have got swallowing difficulties. Yes, please.
I'm sorry, I may have lost one passage, but how did you find the dysphagia condition particularly?
Yeah, great question. So the question is for people who didn't get the question was, how did we identify dysphagia and dementia and others as potential confounders that have not been taken into account? So this was not essentially automatic. This was essentially we ran the models the same, and that is all described in the paper, and just look at what factors associate strongly with both of them, even after the baseline. And some of the strongest are these, and pretty much none of those were taken into account in previous models, and I just picked up the dysphagia as one of the strongest. I think it had a sort of a six-fold, if I'm not wrong, association with mortality and as well as with the drug prescription. Yes?
Hello. So my question is related to the mutually exclusive and collectively exhaustiveness of causes. So are there any such rules when we decide, okay, we have reached to a point where we can make an action? So we have these causes, and these are mutually exclusive causes and collectively exhaustive, and we can make an action now, because the idea for using learning for electronic health records is to assist human beings. And if we are doing the similar mistakes as the humans have been doing in the past, like we reach to a conclusion before it's a conclusion.
Yeah.
So are there any such rules we set for using learning techniques to do that?
Yeah, I'm not sure I get your question fully, but if I understand your question, you're interested to find out whether this, we've got to a point where the causes that we've identified explain essentially all variability in someone having a certain condition, and therefore we just said we've exhausted, we know everything that we need to know, therefore we can, I don't know, now go down the line of intervening. Is that roughly?
Yes.
Yeah.
Roughly.
I don't think, we look at it, more pragmatically, right? You don't need to understand all variability. You don't need to understand all the causes. In fact, the one cause that you've identified itself might not be the biological cause directly. That is why I've explained the principle of causation, the way I understand it in epidemiology, is very practical. If you find something that intervening would reduce the risk of something at the end, that is good enough, right? It might be that I've said, we still don't know, some of the drugs that low blood pressure, is it because directly blood pressure, or what mechanisms in the body go through that? I mean, we don't know. I mean, if you look at across all conditions in biology that we have, even in areas where we understand a lot, like, cardiovascular disease, we can explain probably about 80% of the variability in the population with the risk factors that we know. A lot of them we don't know, and a lot of them could be probably replaced to better measurements. But in some areas like neurodegenerative conditions, we can explain probably something in the order of 10, 20%. But that doesn't mean we should wait until we understand more to just intervene. So, I think from my point of view, you need to take a sort of a pragmatic approach. It's not mathematical to just say only if I've, captured all variability through all causes, then you can just start going to the next step. It evolves essentially, and that is why some of the interventions that we have today are replaced by others, because we find finer tools.
Hi. So a bit of follow-up about this point of whether we need to understand causes or not. Traditional statistician that uses causal inference would argue that as you increase the number of confounders that you're including in your model, you're also including the probability of including colliders, especially if you're including data that's happened after the outcome. Have you looked into ways of maybe then after using this sort of complicated model, looking back and understanding the causes to just check that you're not actually including something that's increasing the bias in your model instead of decreasing it?
Yeah. So that's a great question. I mean, I presume you're sort of epidemiology from background, or you?
So causal inference.
Causal inference, right? I mean, so, I don't know how many people are familiar with the term collider bias. So this is of theoretical great threat in the relationship that we look at. I mean, I showed a sort of a simplified relationship between A and B, and there is a C that is a sort of a common cause of both, right? Collider bias would be where there is a sort of a factor D that essentially goes all the way around, and adjusting for that, you would essentially unblock the bias, and your model output, strangely, by throwing all factors in, could be more biased than not adjusting for it, right? So this is the term collider bias. A lot of people get excited about it, right? From theoretical sense. From what we know empirically in the context of what we do, it just quantifiably doesn't matter. And there are a lot of experimentation, including simulations, that have gone into that, because the signals from the confounders that you might miss is much stronger than any fine biases that you might introduce from colliders. So this is what we know so far. But it's a great question, and I don't think that we've got all the answers in this context. I'm not aware of any studies that have looked at complex deep learning models with T-BERT that we have and looked at essentially potential colliders in a simulated setting. So the original paper that Shishi did, we actually go at length into that. If you're interested, read that, and we do provide some examples into that. But on average, just assume that in that context, it is of a theoretical threat, but practically doesn't matter.
Hi. Great lecture. I really enjoy it. And I was curious about, so along the lines of what he was asking about, knowing all the information about something that might potentially happen in terms of the patient, but you yet don't know. So like, let's see in a clinical trial, you're looking at someone who has the likelihood of getting increased risk and may get sick. Do you pull them out? And I was curious, like, what in your experience, or what have you seen in the application of findings in electronic health records of a certain patient and kind of intervening? And there's a little bit of ethics there. So I was curious, like, not in terms of studies, but in your personal experience, have you seen people already taking this, like, kind of like predictive, like, intervention in care?
Can you expand on that? You mean what do you mean by predictive?
Or like, you see things are trending poorly, but the patient looks fine. And there's a likelihood that they'll be okay, but you're not sure because, like, based on the data you're seeing, you're like, there is an elevated risk.
Yeah, I think you're way ahead of us because I think most of these, what I've described so far is still in the research environment. So we look at essentially the database that we have is not live data where you know who the individuals are. They're completely anonymized data. So we look at the database of 20 million people. What we don't know whether it's you or me or anyone else, and that you can't identify those individuals, right? And you're not directly essentially at the level of individual to be able to provide any feedback to them at all. In fact, that is what we want to do, but as you can imagine, the data governance issues around it are huge, right? At least at the moment here in this country, you cannot access the data the way we have done it with identified information to be able to get to that inference level of advising individuals. So it doesn't happen. All of even the future, when we predict the future, has already happened. We look at historical database. We artificially set the future somewhere further back in the date as opposed to looking at it prospectively. Even for some of those models, we need to do that. We need to develop it and assess them prospectively, but it hasn't been done here. There are tricks about how we split in different way, but we are not concerned at all about people taking action based on the information that we have found, and that essentially would mess up, the relationships. No, that's. It would be good for us to have the concern because that would mean that we have already implemented it, but no, this is just all historical data.
I just wanted to ask, so I think, say, if all disciplines like cardiology loves these like sparse, robustly validated scoring systems for stratifying patient risk and for choosing treatments, etc. So, like, do you think that this is something that will be, say, like, rapidly accepted by the medical community, or do you think there'll be a bit of pushback? What's your own view on that?
Yeah, I mean, it's interesting. I mean, I don't think that the medical community, if you talk about the practitioners, they are just willing to automatically accept that. I mean, essentially, you need to just look at it from the economic point of view. Can you reduce the pain of doing things that they're doing now with less work and at ease, right? That is really the question. What we have at the moment is, and statisticians know that, even if you've got a regression model of, let's say, 20 covariates that would predict the risk with a reasonable accuracy, they tend to simplify it for the clinician to just reduce it to 3 things that they can keep in their head and then calculate it automatically, because they can't do the sort of a 20 calculations. It's just too time consuming from them. So if you go from there, of course, to a more complex model, there would be more resistance in theory, right? So that is why you need to think about not only about the model, but about how you operationalize it, how it's going to get integrated in terms of a practice to be able to just smoothly inform decision making. And we've got some work that is going in that area as well. I mean, I think it is where, whether we want it or not, whether clinicians like it or not, this is where we go, because this is essentially a big opportunity. Instead of making decisions on risk based on a few covariates that get it essentially a bit better than tossing a coin, you could get substantially more accurate. It's just a technical challenge of implementing it and getting into the routine, which is easier said than done. I mean, a lot of time that operational challenges are huge.
So I guess just by looking at, I guess sort of from your talk, there's always this thread of like residual confounding. And I guess I'm not very familiar with the causal inference, but I was wondering if it's sort of a common practice to do like some sort of sensitivity analysis where you assume that you may have like unmeasured confounder with like certain size or like a certain effect on your outcome. And then maybe like use that information to test whether your conclusion still stands or not.
Yeah, it's a great point. Yes, there are methods, and the conventional statistics has moved on over the past few years to just do some validity check of your findings. Sensitivity analysis is one way of doing it, but sometimes still hard to just apply all of them. And the examples that I've shown, they've escaped through the net of doing it, and some of those tests that are employed are not useful. So, I mean, one way of doing it, and a lot of time is done, you just say, well, I mean, I look at, a relationship at the same time that I expect the relationship to be null. So I expect no effect. So if that is also shown, then I'm sort of confident that it was. So you take a sort of a neutral outcome. You could take a sort of a negative outcome where you would expect the relationship to go the other way. And if that also confirms, you get it. But you don't have always those sort of comparisons that you can make. In the case of a drug, you cannot come with those possibilities, right? You can just, come with some other ways of tricks to just saying, well, I mean, there might be some residual confounding. How big can they be before I can conclude that the relationship is just completely non-causal, right? And you can make those estimates as well. But in the case that I've shown here, once your relationship is double the risk, those estimates are just not very helpful. I mean, a lot of those are not mathematically based on some solid foundation. You have to just make a judgment, and at the end, I know the author would just say, oh, we did that, and we think, it's not strong enough to be all due to residual confounding, but, you're left still with the uncertainty. So there is no perfect solution to that challenge. Yeah. I don't know who is next. There's one question there, one question there.
Maybe we could do 5 to 10 minutes, 5 minutes or so to finish it, and then do Q&A and then.
Yeah. So I think this was sort of an open end. I think let me just go a bit further to just see whether there is any sort of a key things that we need to cover. I'll cover just briefly that one about hypothesis generation, just a few slides, and I leave the other ones as well, and then we can go through Q&A and talks. I mean, what I've just shown so far was mainly about hypothesis testing, right? You've got a specific question and you go and test that. But some of the other interesting areas where deep learning can help is also generate hypotheses. Of course, we don't lack hypotheses. You can come with millions of hypotheses when you just open the medical literature. But it is how can you come with more intelligent hypotheses, those that are more likely to be useful. And just give sort of one example of one of the work that we have done. Let's say you want to just find out what are the factors that essentially could cause someone having a heart failure. So this is BERT model in action. So you look at it, and the first thing that we did to just saying, well, if the model predicts the incidence of heart failure accurately, which it does, can we go to the level of explainability and unpack what are the features that essentially make a larger contribution to that. And given that we know that age is an important factor itself, we can essentially stratify further by age and look at those main factors. And what we see here, this is essentially for getting some confidence in the model, similar to the example that I've shared before. If the model is good, it should pick those things that we know biologically somehow linked to the disease, and it picks sort of those major conditions directly. But if you then look at all conditions, it comes up also for conditions that you have not thought immediately as a sort of a risk factor for heart failure. I mean, in this case, could be anemia, it could be some sort of a dermatitis or depression, and the relationship is different by age. And you could do the same thing with medications. Are certain medications that could essentially cause someone having a disease? And again, if you run it by the list, you can again find some things that you thought that could be an issue. Apologies that the font size is small, but all of that is also in some of the papers that we have published. But I want to move from here to the next one, where essentially your contextual information becomes quite handy, and that relates to what I've said before, that the information does not need to be directly captured in the EHR. You can, through contextual information, get some sense of what might be going on. And when we did that analysis to look at the, what could be essentially causes of heart failure, some odd patterns came out that, if you look at calendar years, in some years, in earlier years, it seemed that treatment for glaucoma would increase the risk of heart failure. In later years, it would decrease the risk of glaucoma. And that is quite odd, right? I mean, you give treatment for someone having glaucoma, eye condition, it seems to just cause some problem. And by the way, this is a hypothesis generated, but then later year, it seems to prevent it. And when you look at it, it just, the way the records that we have in touch, you need to make some summary of the information that you feed into the model. So the group of drugs given for glaucoma has one code that enters into the model. When you then unpack it, there are multiple drugs that could be given. And the patterns of drug use shown here in this plot seems to have changed over time. So there are two main class of drugs, the beta blockers and the prostaglandin analogs. And one has declined over time, the other one has increased over time, and they have got biologically different actions. So it is plausible that what actually the model has picked up here is not completely just nonsense. And that it happens that essentially in some years it was a great association, in other years it went to the other direction. It could be because the drug has changed, and this is essentially the contextual information that was indirectly captured in the model, but it requires essentially the expertise going down and unpacking it if there is sort of an interest in that area. So I'll stop there here, and I'm happy to take, I'm not sort of overrunning to any questions that might be.
I have a question about multimodal data in EHR. So, for example, where you've put here, there are some drugs, and that's kind of not obvious from looking at very simple data in the EHR. What about when you have imaging data in your EHR? I know that that's not something you can kind of analyze in the same way. Is this something that people are starting to look at, or do you have an opinion on that?
Yeah, I mean, as you know, pretty much all deep learning is moving towards multimodal. Even your, GPT-4 model is going to the direction that you go from that textual information to additional modalities of data being fed into that, similar, to the work that we are doing. So what I've presented is based on essentially structured data within EHR with different types of information from medications and diseases into that. There is technically no challenge of no reason why you shouldn't be able to integrate, let's say, imaging or genomics or other type of information. In fact, we've got some project that looks into that. The problem is that you have got different scales of information, and you get into that, essentially that imaging, how do you know that is from that patient? You have to go to different types of studies where that has been captured. I mean, to my knowledge, there is no such large data like the one that we have that would have essentially, I mean, genomics, you find them, some of them, there are some databases, but, having essentially raw image data, even some summary image data directly into that. There are some projects that are looking into that, but I think it's very exciting. Would be interesting to just see for specific area in medicine, let's say, where imaging is important in cancer or other areas where that additional modality would substantially improve the downstream tasks.
Especially this hypothesis generation is quite important also to go further in the biological or medical area. So, and that is why I wanted to go back to the slide that you've shown before. So I think that there's still an increase in this risk that you've shown, which is about 30 to 40%. So if I got you right, so I think that there's still something that is not explained, and I think that is the reason why we should go more into that. So that is one thing, and the other thing is thinking about model selection. So I think that we often are confronted with now deep learning is just a really complex model of all that thing, and now I'm wondering whether we should just use that to generate these hypotheses, but then go back to use a statistical model to use the covariates that you found in the deep learning to then learn again a statistical model and use that, because I think it's easier to, as you already said, it's easier to use that and to explain that to the medical collaborators.
Yeah. I mean, I'm not so much concerned about explaining to physicians or other people, because I think we will get used to it. I mean, a lot of things that we don't understand today, either we accept it, frankly, right? I mean, who understands, what that ECG strip, how it comes about when you see it on the printer? No one. But we still say, that makes sense, right? So I'm not worried about that aspects of it, but I completely agree with you. This is not about ML versus conventional statistics, and this is not how we have been working. It is always true that the simplest model that works is the one that should be used, right? But a lot of the time when you get to those complex relationships, they just don't provide the answer. But in the sort of a framework that you described, where you go sort of from trying to just disentangle the complexity, you generate individual hypotheses, it may well be that down the line, a simpler model is a solution. And we've got some work that goes in that area where we're exactly doing that. I mean, I didn't describe it, where you go from sort of essentially completely data-driven clustering way, and then essentially feed additional data modalities and essentially go from feature engineering all the way to hypothesis testing. We haven't gone to that level to just decide which model would be the better one, but I suspect when you get to that level, once the complexity is reduced, some simpler models could be the answer.
The question is about, do you have an estimate when these models become effective? I mean, how large should these data sets be? I mean, have you performed like sample size sensitivity?
No, we haven't done that. I mean, we happen to have data of several million people, and a lot of time we know that when you go for at least for some of the subgroups, you would need that information. Of course, there are tricks, and I didn't go into that, the transfer learning. Once you have applied that model to that large data set, if you can go to smaller populations, smaller data sets to just see how things are going there. I mean, I think there's that is where a lot of the technical innovation goes into that. How can you essentially do that? Go from large to small, still not lose any model performance.
Thank you, Professor Remy, for an interesting talk. I'm Ting from UC Nottingham. I have two quick questions. The first one is about the comment when you make where the advantage of deep learning in healthcare records was to measure unobserved confounders, and also where missingness is less important. But I think it might cause a bit of concerns, I guess, from statisticians or epidemiologists that obviously that's not important. I guess the way I was thinking about it is electronic health records, there's lots of uncertainty that the ground truth, I guess, is not quite there, in the sense that there might be lots of quirks within the electronic health record that a deep learning might pick up that might not be important. For example, some electronic health records where if you don't enter certain data where it's missing, it's because it's more likely to be no when clinicians don't enter it. And I guess, how do you reconcile that within the approach that you use?
Yeah, I mean, I think there's more work to be done there. But in the context of what I've just said, the way I see it, if a healthcare professional would look at your record and there is certain information not recorded. There is no information about you having a certain disease, or you have never had a blood test done. That tells immediately the healthcare professional, gives a signal that you probably belong to a category of, on average, to be healthier than someone very similar age who has got multiple measurements. So the absence of information in that case, recorded information, is information, and that contextual information is captured. That is why I said that essentially you don't need to essentially impute to just have 0, 1 for every field, as conventional statistic does, to be able to do that. And that is the empirical information that we see. Similar to what is now on the slide here. This is the contextual information that essentially captures that. So if an individual looking at all the patterns can essentially say, I know pretty much if I would do the blood test for you, I would expect everything to be normal. It hasn't been done, probably you're in that category, goes into that. But it needs, some work needs to be happening about what, where does it matter, where does it matter? And to your first point about distrust of statisticians, you're absolutely right. We get all that question all the time. I mean, when that comes into some of the papers that we submit, just saying, how do you deal with it? And I mean, I'm not convinced. I mean, so I think we need more work. And if people want to join us and help us with that, would be good.
I was just wondering if you could touch on how you think about sociodemographics and other values that might be really important in outcomes health-wise. Things like socioeconomic status, and how you think about including those in models like this. I haven't read a ton about your BERT model necessarily, but I'd be interested in hearing about it in just some context. Like, I'm from America, so we don't have standardized healthcare, so we have to include that in our models a little usually. Yeah.
No, great point. I mean, what is socioeconomic status? I mean, itself, you could essentially debate, can you measure it, right? In the UK setting, the best indicator of socioeconomic status is where you live, fundamentally, your postcode. Small area that you live in, it pretty much says, whether you are belong to a sort of a higher, if you like, more affluent population or less affluent population. And that information is included in this. So we've got that. So I'm not sure whether it's included in all the models that are described, but essentially is a combination of those factors that goes into it. Yes, it's an important point.
So I think, am I right that there's a data engineering role that is still live in the lab? Or?
Yeah.
So if you're interested in that sort of stuff, come join our lab. There are some JDs live right now. Feel free to apply, and hopefully we're going to be colleagues soon. But with that, I would like to thank Kazem for such a great talk. I wish we could do more Q&A, but unfortunately, we're on a tight schedule. So thank you so much, Kazem.